Welcome to this overview of the research that's been conducted on non-speech oral motor treatments. First, a couple of notes about terminology. The abbreviations you'll see in the literature will vary. Some people refer to NSOMEs, or non-speech oral motor exercises, and others refer to NSOMs, or non-speech oral movements. They're all talking about the same thing, which is the use of treatment activities that teach someone to do something with their oral articulators that is not a speech task. Common examples include puckering the lips, retracting the lips, puffing the cheeks full of air, doing tongue exercises, including moving the tongue back and forth in the mouth, or elevating the tongue to the roof of the mouth repeatedly. Blowing bubbles is another classic example, as is sipping increasingly viscous fluid through a set of straws that are graded in their diameter, such that some straws require very little effort to suck through, while other straws require substantially more effort to draw up a similar fluid. For our purposes, these will all be considered under the same umbrella term, which will mostly be NSOMT, or non-speech oral motor treatment, in this presentation. The topic of non-speech oral motor treatment activities has received substantial attention in the research literature in the past several years. This has been in part due to a proliferation of commercially produced and marketed sets of materials that target non-speech oral motor activities. Clinicians who created these materials have in some cases created whole companies to distribute their materials and approaches, which by itself is not a problem. However, in terms of evidence-based practice, it's necessary to review what we know as well as what we can hypothesize about the likely efficacy of this kind of approach. So a first question we should ask is whether there is any empirical evidence that oral motor exercises are related to the development of articulation skills in children with speech sound disorders. And the answer to that is that there is very little such evidence. However, absence of evidence of an effect is not the same thing as evidence of an absence of an effect. So we can go beyond the current state of the literature to look at what basis non-speech oral motor treatments are thought to have theoretically. If an approach can be shown to be well-grounded in a fully articulated, accepted theoretical framework, then even if there's no current efficacy evidence, we can have some good rationale for using it, assuming, of course, that there are not empirical data to suggest that it's not efficacious. So, let's look at why non-speech oral motor treatment should work. The arguments that have been advanced include that the complex motor task of speech is based on combinations of simpler movement patterns, many of which are non-speech movement patterns. Therefore, training these simpler non-speech movement patterns should lead to improvement in more complex speech motor tasks that rely on these simpler movements. A second argument revolves around strength. Because the speech of some children with speech sound disorders sounds slushy or imprecise, the thought is that the muscles producing that speech might be too weak. If this is the case, then strengthening the muscles should result in improved speech sound production. An assumption that underlies many non-speech oral motor approaches is that simple non-speech oral movements are a precursor to the development of more complex speech movement patterns. This implicational hierarchy would predict that if a child cannot perform a non-speech oral task that's a precursor to a speech task, then it would be a waste of time to work on the speech task before teaching the child how to perform the precursor non-speech task. One last idea is put forth frequently, that non-speech oral motor treatment produces better results than therapy that focuses only on speech. This argument is typically made based on the accumulated clinical observations of a particular practicing clinician. As you're aware, expert opinion is one of the main pillars of evidence-based practice, so argument from clinical experience can be a valid and valuable piece of the evidence base behind any particular approach we take in this field. To the degree possible, however, it's also necessary to evaluate a treatment approach in the light of the data that we do have, and to think critically about the underlying assumptions about why any given approach should work. In the next segment, we'll look at each of these rationales in more detail.